So today we are going to be covering what the evidence and the options are for 3 different categories of pain management in labor. The first one we're going to be covering is epidurals and spinal. The next is going to be IV opioids in labor. And then the third will be nitrous in labor. So let's begin by talking about epidurals and spinals specifically. So epidurals are highly utilized in the United States. So about 70% of births have some kind of epidural for pain management during labor. And there are much lower rates globally, like 20 to 30% in England, about 30% in the Netherlands, and 70% in Sweden. So the epidural is basically a needle that is inserted into the very base of the spine with a little plastic tube that's placed on top of that needle. And so the needle does not stay in the body. Instead, it's used to help thread the catheter or that tube into the body. And so it goes right into the very small of your lower back called the epidural space. And there are many different kinds of epidurals. There are epidurals that do a continuous infusion, which means medicine is continuously being infused into your body. There are also patient-controlled pumps or PCAs, with intermittent doses that result in shorter labors and fewer forceps and vacuum deliveries compared to the steady continuous strips. There's also something called a spinal or a combined spinal and epidural. So we're going to talk about a spinal here in a second, and then I'll talk about what that combination looks like and what some of the different risks are for that. So the next would be the spinal. So the spinal is a single injection of medication. So rather than using a tube to thread into the body, taping it to the body, and then continuously or intermittently putting medicine through that tube into that person's body, a spinal is an injection into the same space. So it goes into the spinal fluid. It works instantly, but it only lasts about 1 to 2 hours. So it's reserved for usually imminent deliveries or a C-section. So if you come in to the hospital and you decide that you do want an epidural, you're welcome to get one. What the journey will look like probably is that they'll have you sit on the edge of the bed, they'll clean and sterilize your back, and then they'll sanitize your back. They'll put the medication in, and then you'll be lying back on the bed after that for a little bit so that we can make sure the medicine spreads evenly throughout your body. I highly recommend, if anyone get an epidural, that they're not on their back a whole bunch. You can move a lot with an epidural. We just have to learn how to do that. And we'll talk about that here in a minute. But specifically, just when we're illustrating the difference between an epidural and a spinal, I want you to kind of understand how some things unfold a little bit differently. So with the epidural, we have to stay on our back for about 15 to 20, even 30 minutes to make sure that the medicine spreads evenly throughout your body. After that, please move as much as you want to move. Nothing is mandatory, so you're not forced to stay on your back if you don't want to, or if baby isn't tolerating labor well when you're on your back. And at the same time, it's a great way to make sure that the medicine spreads evenly and you get the desired effect by staying on your back just for a little bit. After that, please don't get back on your back unless it feels the most comfortable for you. Otherwise, it's ideal to move into lots of different positions. In that, 20 to 30 minutes that we're waiting for the medicine to spread evenly, you might not have that much of an effect. You might still be experiencing contractions. Maybe they slowly feel a little bit less intense and you start to get a little bit more numb. So that's kind of what the epidural looks like. It takes about 30 minutes to work. Once it's there, though, it'll keep working for as long as you want it to work. With the spinal specifically, that's very different. A spinal is an injection of medicine. And so instead of giving it to you continuously, we give it to you in just one dose, which means you get an immediate effect, but it only lasts about 2 hours or so. So this is why spinals are often used for a C-section or if you're about to have your baby. I know a lot of people who have gotten an epidural and they got it in transition. So they're about to have their baby and they felt like, I don't know if I can do this anymore, facing the self-doubt that we often face when we go through transition, and then deciding to get an epidural. And then by the time the epidural is in effect, the baby has already been born. And so now you have the epidural in place, but baby's been born. So you basically had an unmedicated birth. So that's not fun, and that's not something someone wants. So this is why the spinal specifically might be a good option for someone, but the risk is that maybe, baby doesn't come and you still, or you start to like have feeling again. And maybe that's okay for you. Unfortunately, like when I say it's reserved for when delivery is imminent, we can't always know for sure when baby's going to come. You could be 10 centimeters and baby could be right there and still be pushing for many, many hours, still be pushing for 4 hours. I have seen births where the mom goes from 3 centimeters to baby in our hands in 30 minutes. And I've also seen births where the mom is at 9 centimeters for 9 hours. So we just really can't know when baby's going to come. So if you ever wanted to get a spinal because you're really close and it looks like baby could be coming soon, that might be the right choice. And it's also important to recognize that maybe it would wear off and you would possibly regain feeling before baby is born. Is that something that you're okay with? If you're planning a medicated birth and you say, I just want to be numb, I want the medication, right? That's okay. That might not be the best choice for you then. But if you are planning an unmedicated birth and get to a point where it feels like, I don't know if I can do this, I'm really struggling, I think I just need some support, and you take that, and maybe that spinal gives you the time to take a nap and relax and let your body dilate the rest of the way, or let baby come down, and then maybe when you're ready for pushing, you kind of get some feeling back. And maybe that's what you want, right? So you can use these tools in the way that feels best for you. So let's talk about different ways we can exercise self-agency with both of these tools, and then we'll talk about the combined spinal epidural. So one example of kind of exercising self-agency and using a tool to help you through a hard moment would be to get the epidural, but ask for the lowest dose. You could also get the epidural where there is an intermittent patient-controlled bolus, which means that you can push a button and more medication will go to you, and decide not to push the button. You could get the epidural and then you could say, can you turn it off? Like when you get near pushing, maybe you say, just turn it off, and perhaps like you will get all your feeling back over time, or maybe several hours can go by and you don't really get that much feeling back. And it really depends on the medicine that is in the epidural, the strength of the epidural, and there are other factors as well. So it's not guaranteed if you turn it off, you'll fully regain feeling right away. It could take some time, and it's possible that you can regain some feeling, and maybe that feeling is helpful or something that you want, for the actual pushing and delivery of your baby. So these are all ways you can use an epidural in a little bit of a different way than just we get it. And, you can use it a little bit differently in terms of the dosing if you want to have a little bit of feeling, but just have the epidural take the edge off. I will say that it's very important to learn how to cope with labor with an epidural, because even if you're planning one, you still need to learn how to cope until you get to the point where it's time for the epidural. It's really, really ideal to get an epidural a little bit further along in labor. Around 5 or 6 centimeters is great. But, dilation doesn't always mean that much. But waiting until you're deeper into active labor just reduces the risk of the epidural slowing your labor down. And so if you can learn how to cope with labor beforehand, that can help you have a better experience with the epidural, because you can wait to get it until you're at a point where your coping tools aren't really working the way you want them to anymore, and you're ready for a pain management, right? So, okay, let's talk a little bit about the combined spinal epidural. And so the combined spinal epidural is basically when we give someone both. We give them an injection of medication, and we also give them the epidural with the continuous infusion. And so the idea is that you're going to get fast infant relief plus the continuous medication. A lot of people say that this is a walking epidural. They call it a walking epidural, but that's actually a myth. A combined spinal epidural does not increase the likelihood for you to have movement. It doesn't increase mobility. And it actually carries a higher risk of maternal itching specifically, and fetal heart rate drops. So there are more side effects to the combined spinal epidural. So if you're really wanting to get pain management but reduce the risk for side effects, choosing either the spinal or the regular epidural is probably a better choice. So let's talk about the pros of the epidural and the spinal. So this is the most effective pain relief available. It's safer for the baby than the IV opioids because there's less respiratory depression seen when babies do the epidural compared to the IV opioids. It does not raise the risk of C-sections or severe tearing. It does increase the risk for tearing, but not severe tearing. And it can be quickly dosed up if an emergency C-section is needed, so you can get one relatively quickly, which is really great. And now let's talk about the cons. So it greatly increases the risk of maternal blood pressure drops. So there's an 11 times higher risk of your blood pressure dropping if you get an epidural, and it increases the likelihood of a maternal fever. That increase is 3 times higher. If your blood pressure drops, sometimes this can initiate the cascade of interventions. A cascade of interventions is where we get an intervention, and then that intervention leads to the need for another intervention, which leads to a need for another intervention, and now we ended up getting all these interventions. So epidurals do not equal a cascade of interventions. I want to be really clear that you can have a great experience with an epidural. And an epidural doesn't mean that all these other horrible things are going to happen. But there is a risk whenever we mess with physiology that potentially a problem will occur because of what we did to mess with it. And then the side effect to that is that we need some kind of other tool to help with that side effect. And then because of that, there's a side effect to that thing, right? And it goes on and on and on. So that can happen. And it's important that you understand that that's a possibility. A lot of people get an epidural and then they take a nap and then they wake up and they push their baby out and they have a really great experience. But there are some people who get an epidural and that causes one problem and causes another problem, which causes another problem. So that can happen. And I'm illustrating this to you not to scare you, but to make sure that you understand that it's always a possibility, right? Whenever we mess with nature, whenever we use a medical tool, that a side effect can happen and that can take us down that path. One example, I'll share a story of the mom who was 9 centimeters for 9 hours. She got the epidural and her labor was still progressing normally, so it didn't slow her labor down, but it did cause her heart rate to drop because her blood pressure dropped. So blood pressure dropped and then her heart rate dropped a little bit and then baby's heart rate dropped. And when baby's heart rate dropped, that was really scary. So everyone ran in the room kind of freaking out about what was going on. And they said, we're doing the external monitoring, and since the baby's heart rate is dropping and the monitors can slip, we just want to have consistent knowledge of exactly what the baby's heart rate is in every second. Can we do internal monitoring? And she said yes. So then we do internal monitoring, which means we're going to break the water and we're going to administer that little copper spiral into the baby's scalp, which can cause, pain. It can cause bleeding or hematoma, infection. That's rare, but that can happen. So that comes with its own risks. Breaking the water comes with its own risks. And then an intrauterine pressure catheter, which is a tube that's placed inside of the uterus to measure the uterine contractions and the strength of those contractions. So now we're doing internal monitoring. They give the baby epinephrine to bring the baby's heart rate back up. But now the baby's heart rate is really high. It was in a normal place and then it dropped and now it's really high above the normal range. And then they start to go, because the baby's heart rate is high, that might mean that you have an infection. So we should give you antibiotics. So then they give the mom antibiotics in labor, right? And so this is an example of how one thing causes another thing, which causes another thing. And she ends up having a very, very intervention heavy birth. And that wasn't what she wanted. An epidural and a spinal block are packaged, or I'll say it this way, a bundle of interventions. They're not just one intervention. They come with many other interventions and they come with many other forms of monitoring. So one other risk of the epidural and spinal is that we need to, be closer to the bed. We have to have different forms of monitoring, and all those things come with their own risks. First off, there's continuous monitoring, which if you were doing intermittent before, now we're doing continuous. Continuous does increase the likelihood of cesarean without improving outcomes for babies. They can slip off the belly and be kind of annoying sometimes. They can impact mobility and be if they're wired, then we have to kind of navigate those wires. If they're not wired, it's not that big of a problem usually. Internal continuous monitoring does increase the risk for infection and some of those other risks for baby that I talked about. And then there's the blood pressure cuff. So they'll give you a blood pressure cuff and it will just be connected to a machine and it will go off spontaneously on its own, every 5 minutes or so. And then we'll over time increase the duration between when it's doing that, just to keep an eye on your blood pressure. There'll be a pulse ox on your finger, which is connected by a tube or a wire to a machine as well. And then you won't be able to control your bladder. So they need to catheterize you with an epidural. Sometimes that looks like an intermittent catheter, which means we'll do the catheter and then we'll remove it. And then we'll do it again later and then we'll remove it. An intermittent catheter is nice because you don't have to keep a catheter in. Yay, and we love that. Unfortunately, the intermittent catheter does increase the likelihood for infection. So a lot of people will just say, we just want to give you the catheter and have it be there. So that's quite a lot of tubes. If you think like from your arm, tubes from your belly, or wires, to machines on your finger, the catheter, there's a lot of things going on. And some moms will say, didn't bother me at all. I didn't notice any of that. It was totally fine. Other moms are like, that made my birth feel like a medical experience rather than a normal physiologic experience. And I really didn't love that. So the experience of birth can definitely change. And that might be something that's important for you to consider if you're a person who really doesn't want to have a more medicalized experience of birth. So let's move on to some other risks. Other risks include causing heavy legs or a complete motor block. So sometimes you can have the epidural and you can still kind of move your legs around. Other times you just really can't move them at all. Another risk is urinary retention. And so we talked about this with the bladder, with the catheter, but I also wanted to add that the catheter does increase the risk for a UTI, which would require antibiotics in the future. And then the epidural also can lengthen labor. There are more rare risks, and so these are very unlikely to happen, but they are things that you should be aware about. And so that includes temporary nerve damage or spinal headaches. And so temporary nerve damage means that ongoing you have some back discomfort. I don't know if you know anyone who has gotten an epidural and then they have back discomfort or back pain going forward in their life. That doesn't happen to everyone. Obviously, a lot of people have an epidural and have a great experience and recover just fine, but consistent pain in your back ongoing is possible. Normally it's temporary. I do know people who experience that, throughout their whole life, 20, 30 years later, 40 years later, still struggling with that. So something to be aware of as well. Okay, so let's talk a little bit about what the research has to say on epidurals. So there was a big database study that showed epidurals reduce the relative risk of severe but rare maternal complications by 35%. However, the absolute risk only dropped from 0.43% to 0.28%. So the study also noted that the epidural group had double the C-section rate, likely because the group had more first-time parents and inductions. Major medical bodies state that epidurals should be available upon request at any dilation stage, and they are also safe for VBACs. And contraindications are rare, like the severe neurological issues or low platelet counts, things like this that can come up with epidurals. Those things are very, very rare. I feel like that's a pretty good summary on the information on epidurals, kind of what to expect, what the risks and benefits are. Let's talk a little bit more about positioning for an epidural and what that looks like. So if you choose to get an epidural or a spinal, like I said before, you don't have to stay on your back. It's really ideal to wait on your back for a little bit to make sure the medicine spreads evenly. If you're ever experiencing an epidural and you're noticing your whole body is numb on this side, but the other side of your body is not numb and the sensations are really intense, you can totally sit upright in the bed if you want to, or you could try kind of going more on your back, and sometimes that will fix it. So just so you know, epidurals can fail. They're very, very good at what they do when they work, but they can fail. About 10% of the time, the epidural is not going to work the way that we anticipated that it will. So it's important to acknowledge that and have some tools to kind of work around that. And that looks like changing positions and being more upright to hopefully support the medicine spreading evenly, asking them to redo the epidural, or having labor coping tools. So maybe you're getting partial pain relief, but not full. So we're just going to work on our other labor coping tools like position changes, low sounds, breathing, music, things like that to help you get through the experience, especially going through an experience that you weren't expecting to have if you're planning to have an epidural, right? Because that can sometimes feel kind of overwhelming. So with a position, after we've gotten it to a place where it's working well, this is my formula that I teach for coping with labor, specifically with the epidural, like changing positions right during labor. So the first would be to lie on your side, and lie on your side with a peanut ball between your legs. That's really important. And rather than having the peanut ball just between your knees, I invite you to have your bottom leg that's on the hospital bed just kind of be like straight, like maybe a little bit back behind you. Take your top leg and put it over the peanut ball that way, and then maybe hug a pillow. Stay like that for 15 minutes and then go to the other side. There's something called rolling with an epidural where you're kind of like, I'm upright and then I'm on my side and then I'm in hands and knees and on the other side and then I'm back upright, right? So we're kind of like moving through a series of positions. You could totally do that too if you want to. I recommend first, if you're tired especially, just rest and lie on both sides kind of back and forth. You can go on each side twice for 15 minutes on each side. After an hour, we should be all done being on your side and we should get up and moving to a different position. The reason why we are okay to skip this step though, so like lying on your side longer, is if you need to sleep and you are sleeping. So if you need to sleep and you're sleeping, just sleep. It would be great if like in 30 minutes someone could just kind of gently guide you to like turn over and you can fall back asleep. I really wouldn't stay on one side of the pelvis for too long during labor. And the reason why is because the pelvis is meant to move during labor so that the baby can get into a good position. And one of the reasons why epidurals lengthen labor specifically is because we are not moving very much during labor. There are a few other reasons, but that's like the main one. So if you can imagine, if you're lying on your side like this, if you're here, this part of the pelvis has the ability to move, right? But this part of the pelvis that's lying on the side that's compressed can't move because we're compressing it into the bed. And so it's okay. We want to move this part. We want to let the baby have the space they need to kind of navigate. And then after a little bit, we should go to the other side to give this side the chance to do the moving and this side the chance to be compressed. Because if we're really just favoring one side or staying on one side for a really long time or just not really changing positions, it's a lot harder for the baby to navigate the pelvis. Babies don't just like go in the pelvis and go out of the pelvis. Babies go through a series of positions to help them navigate the pelvis, including tucking their chin, engaging in the pelvis, and descending, doing their internal rotation, and then coming out, and then turning their shoulders, so turning to the side, and then coming out. So they're kind of corkscrewing their way through the pelvis. They aren't just going like in and out. And so in order to give them the space to do that, we should focus on opening the pelvis frequently throughout birth. We have research that shows that dancing in labor actually makes pain reduced and it also makes birth faster. And that's because we're opening the pelvis frequently. So we just need to make sure that we're doing that with an epidural. So I would do that on each side as long as you're awake, or you could take a little nap if you want to, but rotate every 15 minutes. After that, move into hands and knees. On hands and knees, you can lean over the top of the hospital bed. You can bring the bottom part of the hospital bed down and you could put your knees here and the top part of your body up here, so you're leaning over the hospital bed that way. And then you can stay like that in that neutral position for a while. You could lift one leg up into a lunge. You could lift the other leg up into a lunge and then back in the neutral position. You can move your hips side to side, do hip circles with your hips, and just adding a little bit of movement in that hands and knees position. So play around in that position for about 15 or 20 minutes. Another position that you could do is squatting. And so squatting is when we take the squat bar and we put the squat bar into the edge of the hospital bed, and you can lean forward, holding on to the squat bar, rock your hips side to side, right, if you want to do that. I also wanted to share that we can also resolve a positioning issue with an epidural. If we find out that, for example, the baby is asynclitic, which means the baby's head is tilted to the side, you can totally help encourage the baby to exit the pelvis, realign and go back in the pelvis in a good way by doing an inversion on the hospital bed, even with an epidural, or multiple inversions. And what that looks like would be putting your hands in the front of the hospital bed, the part that we can move down. And then your knees are on the other part of the hospital bed that doesn't move down. So you're kind of upside down like this. When we hit the button, the bottom part goes down and your booty goes into the air. And so we get baby to kind of go upside down a little bit. I'll show you actually with the pelvis. So if baby's in the pelvis like this, and then you go upside down, what happens is baby goes upside down, they can come out, correct their position, and then go back into the pelvis in a better way. And so you can do several inversions in a row if we find out that there's a positioning issue, even with an epidural. I recommend when you get a cervical check, the soonest cervical check around the epidural. If you get one right before, for example, you get one after, let's figure out if the baby is well applied to the cervix, what the baby's station is. If the baby is floating above the pelvis at -3, the baby's really deep in the pelvis at maybe +1, something like that. What's going on with the baby's station? Let's figure that out. And let's also figure out the baby's position. Because if they tell you the baby's really favoring the left side and the baby is like up pretty high in the pelvis, then we should do the positions that you'll learn about in my coaching program to support adjusting that. And this is how you can really change the game with birth. But because if you know what the positioning issue is and you know how to correct that, that just changes everything. So you can go into, if you're in my coaching program, you can go into that lesson and you can look at exactly what we do if we're in that situation with an asynclitic baby or a baby facing forward, for example, and then follow those instructions. And most of those positions you can do with an epidural. So when it comes to pushing, what I recommend you do is go through that same kind of sequence, but I want you to do the sequence more quickly. So I don't want you to stay pushing for a really long time in one place or another. It's good to move frequently. So what I recommend is to push for 5 minutes on one side. Then push for 5 minutes on the other side. Push for 5 minutes on the other side, 5 minutes on the other side. So instead of 15, we're doing 5 on each side. After that, we can move into hands and knees. In hands and knees, you can push just like that with neutral legs for 5 minutes. You can lift one leg up into a lunge and push like that for 5 minutes. You can lift your other leg into a lunge and push like that for 5 minutes. And then you can bring your knees together and your feet out. And I have a video explaining how to do this inside my coaching program. And you can push like that for 5 minutes. Yay! So that is what that looks like. After you do that, if you want to squat, you can totally squat too and do pushing there. The only thing is that squatting does increase the likelihood of a more severe tear because there's a lot of pressure on the pelvic floor, if that kind of makes sense. So side lying and pushing on your hands and knees is a much better way to push and protect the perineum and do what feels right for you. It's good to move frequently. If baby gets close to crowning in a squat position, you can always release from the squat bar, get back into a side lying position and deliver the rest of the baby in the side lying position. So great. Now, before we continue, for those who are not in my coaching program, I'm just going to drop the link right here to schedule a free birth breakthrough session with me. So that's a free call where I'll clarify the steps needed for you to feel confident and prepared for birth and also explore how I can support you in the coaching program. So click the link to book a call. Let's get into number 2, which is injectable or IV opioids. Sometimes opioids are administered in an injectable way, so they're given to someone into the muscle. Other times opioids are given in an IV. It's more common in the United States to get opioids in labor through an IV. So let's talk about what IV opioids are and what some of the risks and benefits are. So IV opioids are systemic medications that are injected into the muscle or into the vein, and they dull pain globally, so throughout the whole body, without numbing the body or restricting movement. So it's really, really ideal to consider this tool if you are not wanting a super medicalized birth, if you're not wanting the blood pressure cuff and the catheter and to lose a lot of feeling, but you're also going through a period where you feel like you could just really use a little bit of help. IV opioids are a really great option. So there are a few different options. There's fentanyl, there's remifentanil, there's Nubain, which is also known as nalbuphine, and then there's Stadol or Butofor. I will also say that Dermal or Pethidine is not recommended anymore. That was a really common one for birth, just around 100 years ago, but it stays in the newborn system for days, so that's why it's not recommended anymore. Okay, so let's talk about the pros. So before we go into this, I will just say that remifentanil is the safest form of IV opioid that we have. It comes with the least risk, and unfortunately there is no IV opioid that doesn't have any risk. They all have risk, but remifentanil has the least risk. The benefit is that they're universally available, they're pretty cheap, they're fast acting, they're far less invasive than epidurals, and they are associated with slightly shorter labor. So this is a really good backup if an epidural is medically contraindicated for someone or labor is just moving really fast. If someone doesn't want an epidural, but they want to have a little bit of pain relief. I have seen many people planning an unmedicated birth, and then they go into birth, and for whatever reason, maybe it's a longer experience or it's really intense and they're getting exhausted and they're like, I just really need a little bit of a break. IV opioids is a great option for those people because you can still move around. You can do whatever you want to do. It doesn't really change much about what you're experiencing except for the fact that you have an IV pole and now you have a little bit of pain relief. It won't make you not feel the contractions, but it can definitely take the edge off, which is really great. With continuous monitoring versus intermittent monitoring with IV opioids, it's interesting. I have seen in some hospitals, they continue to do intermittent monitoring even with IV opioids. In others, I've seen that they want to do continuous monitoring to make sure the baby's tolerating that okay. So that may or may not come with continuous monitoring. Either way, it does come with the IV pole, but otherwise, you aren't getting all those other interventions. So next, let's talk about the cons. So the pain relief is unreliable. It's rated poor to moderate. So it causes, in addition to that, significant maternal drowsiness. It can cause dizziness, and it can also cause nausea. Those are the risks to mom. For baby, these are the risks to be aware of. So because these drugs do cross the placenta, they can cause fetal heart rate changes. They can cause depressed newborn breathing, low APGAR scores, and lethargy, which can complicate early breastfeeding. Also, they are usually cut off well before the pushing stage starts, and that can really reduce those risks. So with an epidural or a spinal block, you can get them anytime. But when it comes to IV opioids, we want to make sure that that medicine is not in the baby system in really high amounts right before birth, because if so, it can definitely increase the likelihood of baby needing resuscitation, after they're born. And so typically if someone wants to do an IV opioid, it's recommended to do a cervical exam to see what's going on, because if they discover you're 8 or 9 centimeters and the baby's really low and it looks like maybe they're coming soon, once again, we can never know that, right? But it makes sense to maybe consider alternatives if you're really close to delivery, just to reduce the risks to baby. But for someone who maybe there's a positioning issue with baby and it's making labor more intense and they're 4 centimeters, we might have to kind of correct a positioning issue before baby comes. It's much less likely the baby's going to come super soon, in which case that might be a safe situation to take that medicine and reduce the risk of baby having trouble breathing after they're born. Baby still can, have some kind of side effect. It can cause the lower heart rate sometimes, but typically just a few doses. They only give you so many, but within that safe range, often babies are able to tolerate okay. So there are also some special considerations to consider. So one would be with remifentanil. It's really fast acting. So it hits you in 20 seconds, but it also wears off really fast. It is the safest opioid for a baby, but it does carry a rare risk of maternal cardiac or respiratory arrest. So it requires strict 1-to-1 nursing, a timed pump lockout, and continuous oxygen monitoring. With Nubane and Stadol, these should never be given to someone with a history of opioid addiction because they can trigger sudden withdrawal symptoms. That is some information on IV opioids in labor. Next, let's talk about nitrous oxide, also known as laughing gas. So, a 50-50 blend of gas and oxygen inhaled through a mask is what nitrous oxide is. It's very popular overseas, in the UK, all across Europe. It's used in up to 70% of births in Nordic countries and currently expanding across the United States. Some hospitals have nitrous oxide, some hospitals do not. So I would recommend asking. Some birth centers and even home births can carry nitrous. Never seen that in the United States, but in the UK, other countries in Europe, I have seen that. It's really interesting. So in the US, I have seen some birth centers have nitrous. So ask your provider if that's something that they offer. So this is cool because the patient controls the dosing. So for the maximum effect, inhalation must begin about 30 to 45 seconds before a contraction peaks. So if you can think of your contractions, I've heard of this both ways actually. You can think of your contractions like a mountain and you get to the peak or the top and then you go back down. I really love the idea that your contractions are the opposite. It's not a peak or a mountain you're climbing, It's a hill you're going down, so you're relaxing down into the contraction until you get to the bottom and you come back up. Either way, when you get to the most intense part of the contraction, that is where we want the medicine to already be in your system, right? So 30 to 45 seconds beforehand. Contractions last about 60 to 90 seconds and typically peak, meaning reaching the most intense part, somewhere around the middle. So an ideal time to take this would be if starting to feel a contraction come on. So we grab the mask, put it to the mouth, and we take a big deep breath in, and then we blow out, and you have a little bit of that support throughout the rest of that contraction. This leaves your system very quickly. So it works in about under a minute, and then it's like kind of gone. Like you're not feeling the effect anymore. So if you don't like it, it wears off quickly. It's highly affordable. It's non-invasive. There's no IVs. There's no bed restrictions. There's no bladder catheters, right? It acts by reducing anxiety and creating a sense of detachment, which helps people cope with sensations rather than trying to fight with sensations. So if someone's having a hard time relaxing, this can be a tool that can be really helpful. The cons involve, first off, it's a much weaker pain relief than an epidural. I saw a mom one time who was really exhausted, totally at her pain threshold, and really truly needed an epidural. That was the right choice for her. But we decided, let's go up the ladder of all the different options for pain management first before we go straight to the epidural. And I think that's a really great idea. If you think, I think I need pain management, you could start with the nitrous, move to the IV opioids, and then move to the epidural, right? Because maybe by the time you get to IV opioids, you're doing okay, and you maybe are able to avoid an epidural if that's something you want to avoid. So with this mom, she decided, okay, I'm going to do the nitrous first. And she put the mask to her mouth, and she took a breath in, she took a breath out, and then she said, that don't work. So she was in a situation where the nitrous wasn't cutting it for her. She needed something else. But for someone else who maybe isn't that exhausted, maybe the nitrous really is the right choice that really can help you get through a contraction or several more contractions until you have your baby. So about 69% of users do eventually switch to stronger medications, particularly if their labor is induced or they start the gas very early. I will say that in this case, the gas is a great way for someone to delay getting an epidural, because it is really ideal to get the epidural a little bit later in labor if possible. So maybe if you are noticing baby is still kind of high up, we're not dilating that much yet, and you're still already you're starting to feel like this is kind of getting hard. I think I do want something, but it'd be nice if I could wait a little bit before I get the epidural. You could do the nitrous for a little bit, and that could potentially delay you getting the epidural, which maybe can make the epidural have less side effects because we're getting it later in labor. Common side effects of nitrous include nausea and vomiting. About 13% of moms experience that. Dizziness or drowsiness or claustrophobia from the masks. Altitude also matters because higher altitudes equals lower gas concentration, which results in fewer side effects. There are also theoretical, though unproven in labor settings, concerns about B12 depletion and ambient gas exposure to healthcare staff. That is my conclusion on the 3 different options for pain management. Thank you so much for being here and being part of my training today. It was great to have you all, and have a beautiful rest of your day. Bye.